You're listening to the HNC Let's Talk podcast, hosted by Dexter Brooks. Thanks for tuning in to HNC Let's Talk podcast. We partner with subject matter experts to provide candid conversations on health and lifestyle. Here at HNC Let's Talk podcast, mental, physical, spiritual, financial, and health are all connected. This episode of HNC Let's Talk podcast is sponsored by HealthNet Co. Together, we make insurance simple.
Good afternoon. This is Dexter Brooks with HNC Let's Talk podcast. How is everyone doing this Wednesday? Happy Hump Day. I am very pleased to introduce you guys to Dr. A.J. Velour. I've been bragging about this for the last month about bringing Dr. Velour on. Dr. Velour is a pain management specialist. He is double certified in both anesthesiology and pain medicine. Dr. Velour was fellowship trained in pain medicine right here at the University of Colorado School of Medicine. Right, see there?
That's right.
Prior to that, Dr. Velour received his bachelor degree of science in microbiology at the University of Maryland, and then attended Georgetown University, where he completed his Doctor of Medicine degree. After that, Dr. Velour then went on to anesthesiology residency at the Mayo Clinic, where he served as the chief resident in his last year. Dr. Velour, without ado, how you doing?
I'm doing great, Dexter. It's a pleasure to be here. Thanks for bringing me on. I'm so proud of what you're doing, how you're reaching out to people, and I'm blessed to be on here with you. So thank you.
You're very welcome. Glad to have you on. So let's touch base on pain management, because I'm going to ask a few questions just to go a little deeper into pain management. So it's not the same as someone stubbing their toe, right?
Definitely not the same as someone stubbing their toe. Pain management, it's kind of evolved into its own specialty in a sense. You know, it's a subspecialty of anesthesiology or physical medicine, but I could almost make an argument that it should be its own residency and its own specialty with how much we've learned over the last 10 to 20 years. So hopefully that's the way that pain management is evolving towards.
Because I know that from personal experience, there's a lot of people that suffer with chronic pain. And I want to touch base on, because there's like this little thing where people say, well, you can do weed and don't even worry about it because we're Colorado.
We're in Colorado, baby.
We're in Colorado, you know.
Yeah.
But I'm the type of person like, well, no, I want to treat it. And so what would you... Okay, let me give you a little bit of history of myself.
Yeah.
Okay. When I was younger, I had spinal surgery. And for those of you who don't know, scoliosis, which is curvature of the spine, I had a Harrington rod installed, which is from my neck to my waist. So as I gotten older, it started causing tremendous pain. And so in the last 2 years, I suffered from chronic pain. And thank God for Dr. Velour. I've been able to manage and starting to get back a little bit of my life back. But for 2 long years, I was unable to do anything. It's excruciating, it's suffering. You don't do anything but lay down, sleep, and try to figure it out. You crawl up as a baby. So for people like myself, for people that have like arthritis or any type of chronic pain, let's talk about treatments.
Yeah, absolutely. We'll back up a little bit first and just talk about the evolution of pain management and why I think people in your situation may have been undertreated or underserved over the years. We'll back up a little bit to the field of emergency medicine, which is, I know, something we weren't expected to talk about here, but, you know, back in the day, 20, 30, 40 years ago, emergency medicine, believe it or not, was not a specialty. All it was, internal medicine doctors, pulmonologists, trauma surgeons who would just go to the ER to cover shifts here and there. And as a whole, it was sort of underserving those people with emergent medical conditions and urgent medical conditions and traumatic conditions, because you had this sort of amalgam of different people covering these ERs, not necessarily knowing how to best treat these patients. Not saying that they didn't want to or didn't necessarily know medicine, but someone comes in with a bad trauma from a motor vehicle accident.
Mhm.
You don't necessarily want a pulmonologist or someone trained in lung medicine treating a broken leg that needs emergent surgery. Do you see what I'm saying?
Yes.
And so over the years, emergency medicine evolved into its own specialty. And now we have these amazing emergency rooms where you can go and get treated very, very, very well. Probably much better than most of the world. Let's be honest about emergency care in the United States. It's phenomenal. And so the same thing has sort of happened with pain management, where people who were managing pain typically were kind of your primary care physicians or whatnot. And it was something that they simply had not had the training to treat chronically.
Mhm.
If you see a broken bone, most anyone can at least create a management plan for that.
Okay.
But let's bring up your situation in particular. You're going to have pain from this giant rod that's essentially up and down your thoracic and lumbar spine.
So they could literally say pain in the ass, right?
A literal pain in the ass. And so, you go to a primary care, they say, okay, well, you have pain. Let's send you a surgeon. You go see a surgeon. They say, well, the rod looks good. You shouldn't have any pain. What do you do in that situation? So I think over the years, there's been a big push to have people who can specialize and understand the pathophysiology of chronic pain, because it's very different than acute pain. Chronic pain has different pathophysiologic mechanisms that lead to these conditions. And it's important that you have someone who's well-trained and well-read in managing these conditions.
Absolutely.
So kind of where pain management has gone, we unfortunately still suffer from the label of, from some unscrupulous individuals, 10, 20, 30 years ago, where they, made these so-called pill mills. And that's just a fact of the matter. And to this day, there is some stigma about going to see a, quote unquote pain management, practice. What are they going to do? Just give me pills? Or there's some uncertainty as to what we can actually do. But when you actually look at what we do and what we train for, let's be honest. I mean, anyone with a medical degree can write a prescription for, you name it, opioid. Anybody can do that, but to actually understand how to use that medicine, to understand the pathophysiologic mechanisms of why someone has pain, there's a lot more involved in that. And some of the things we can do, and this would, we would be talking here for hours and hours, but things we can do,
we got an hour. Let's go.
Implantable devices for neuropathic pain, meaning intractable nerve pain from, say, surgical injury, post-surgical pain, traumatic injuries, motor vehicle accidents, any sort of nerve injury where a person is having 24/7 pain from what we call ectopic discharge of a nerve or nerve bundles. We can treat with electrical stimulation, implantable, minimally invasive, almost microscopic implantable devices. Things like radiofrequency ablations that we can do for joint pain. We now have minimally invasive devices we can put in, in people's spines for spinal stenosis, where, back in the day, the treatment options for all of these were A, cut the nerve out, B, cut the nerve bundle out,
Really?
C, cut the problem in the spine out. Whereas now we can do things where we preserve a person's anatomy and we can actually modulate the pain, as opposed to traumatically taking out a painful area and causing more pain. So there's a lot we can do, and it's up to us as a medical specialty or subspecialty formally, but really a medical specialty at this point, to promote ourselves and let people know that there's a lot people can do. There are things people can do within more reason than they would think to promote a healthy lifestyle. And it's not just, here's a bunch of pills, we're going to sedate you, and that's it. Long gone are those days 30, 40 years ago where that's all we had. We have a much better understanding of these mechanisms of pain and what we can do now.
I mean, I've been in the healthcare field for a long time, and I never had heard of pain management. So when did this all take place? When did this type of...
I think it started making a big push probably in the late 90s or so. I would probably judge that as kind of our maybe era of enlightenment, so to speak, where we started to realize that pain is a chronic condition. It's not only an acute condition, and it's not something that can just be fixed like an on-off switch. You know, if someone has a fracture of their arm, sure, you can fix that fracture, but what about the residual effects? I think, again, and I keep harping it back in the day, it was, okay, let's fix this problem and we're done. But we never actually analyzed what is the impact on a person's life where they're now, let's say, in a wheelchair, or in your situation where you had a big surgical procedure done, you have a change in posture, you now have a change in lifestyle, you have a change in needs, you have a change in quality of life. How does that impact you on a daily basis? In the past, that would be very underserved and almost ignored because, you know, there's an X problem, Y was done, and now you're Z. You're okay, you're good to go. But people don't understand that Z is not what X was. It's not your life prior to whatever the surgical procedure was, an injury, a trauma, anything like that. So I think in the 90s, there was a push to understand why are people having these experiences and this type of pain, and what can we do for it? So fortunately, I'm one of the beneficiaries of it, you know, where I trained in the late 2000s and early 2010s, where an identification of these pathophysiologic mechanisms sort of came to light. And I'm also a beneficiary now because I think the future of our field, if we take care of it in the next 5, 10, 15 years, is going to be profound. I think some of the treatments that are going to come out are going to blow people away, including ourselves, because so much time, money, and research has finally been put into this, because we see how much loss of productivity, loss of quality of life, and sadly, loss of life there is with untreated chronic pain.
So let's touch base on a little bit of that treatment, because, like, for me, I believe in ergonomics. So I always tell people, if you're going to work in the corporate world, you're working in any job, there has to be ergonomics in place, because people don't realize if you're sitting behind the desk every day doing the same thing and not stretching, not moving, you're not in a comfortable seat, your desk height is not accurate, your computer height is not accurate. Like now, your microphone is not accurate.
Sure.
You know, it will cause a strain. You will start having pain eventually. But what are some of the ways that you guys do treat chronic pain?
So if you're talking from a preventative standpoint, there are certainly, you know, a number of individualized things we can do when we identify patients who are at risk potentially for developing chronic pain, and that, you know, ergonomics is just one kind of subset of what we do. Certain manual therapies, physical therapies, things like that, where we have identified, let's say, a hot spot. Let's say we have a little bit of slippage of a vertebrae, you know, let's say, in my case, L4 and L5. You know, I come in, I present, you know, I have some low back pain. My life is still pretty good. I play with my kids. I'm able to ride bikes, go on hikes, things like that. But I've started to feel this twinge. You know, subsequent diagnostics have indicated that I have a little slippage of L4 and L5. So now I'm at risk, if I don't take care of myself, for worsening that slippage, for having, you know, degenerative disc disease, for getting spinal stenosis, acquired spinal stenosis. So it's very important to, you know, work on things like core strengthening, maybe bracing, things like that, watching out with what I do within reason. That would just be kind of a sample preventative sort of plan. Now, let's say that injury or that pathology has progressed, and now I'm presenting and I've ignored this for 20 years. And now, you know, I'm getting a numb foot, you know, my leg kind of burns when I walk upstairs, things like that. You know, then we're past that preventative care, because now it's really manifesting to be a life-altering issue. Then we're talking about things like cortisone injections, maybe minimally invasive spine stabilization, things like that. What can we do to prevent surgery? Because we know that surgery, while it fixes a problem, and of course we need surgery, it may cause other problems, maybe in lesser intensity, maybe higher intensity down the line. What can we do to prevent that? And a lot of that will overlap, you know, bracing, PT, things like that. But we have injections and things like that where we can treat that and not only restore kind of functionality, but also help with pain relief and quality of life as well, with injection therapy, radiofrequency ablations, things like that.
Man, that's a lot to think about, because most time people think about, well, how long am I going to be out of work, or how long am I going to be able to play with my kids? Like, for me, my whole life from just having to have the spinal surgery changed my life, because my goal was to be a gymnast. I was actually on the rings. So I was doing that, and all of a sudden I had the surgery and the rings went away.
Yep. And it's unfortunately a sad story you kind of see, because oftentimes when we as a medical field, just the profession of medicine, sometimes may get tunnel vision in fixing a problem, but not understanding how a person's life revolves around that problem and how that lifestyle is going to change after that potential treatment. So I think, again, I'm sort of a beneficiary of this, where we started to see kind of maybe we focus less on this sort of objective, can we fix X to result in Y, but also focus on functionality, quality of life, sleep habits, things like that, and kind of factor all those things in before making a decision moving forward.
Awesome. Now, you spoke of spinal stenosis.
Very debilitating disease, or condition, I guess I should say.
Okay. Because I was like, okay, what exactly is spinal stenosis?
So unfortunately, a lot of people in this country are afflicted by spinal stenosis, and a large portion of people don't actually realize it. And so as we age and some of the structures in our spine start to degenerate, just like your knees can get arthritic, your spine can get arthritic. The spaces in between the vertebrae, which are, the bones that make up the spinal column, those spaces can get smaller because of, let's say, degenerative disc disease, which is also another common thing that happens as we age. That coupled with someone who has a genetic predisposition, say they have a history of, spinal problems, we're going to say quote unquote problems, because a lot of people don't actually understand, what's going on, because we didn't have diagnostics for their mom or their grandparents or things like that. But they always say, yeah, my grandfather, he just couldn't walk the last 10 years of his life. And, that's sort of a red flag for me, knowing that there's a genetic component of maybe, say, spinal stenosis. But that involves a narrowing of the spinal canal, and that narrowing of the spinal canal results in compression of the nerves. We've all heard the term sciatic nerve. It's a catch-all term. Any leg pain is a sciatic nerve. And so when you get compression of the nerve roots that comprise the sciatic nerve, you get that burning pain that goes down the legs. It's a very debilitating condition. And fortunately, we've evolved to the point where us now as pain specialists are able to essentially non-surgically treat that type of pain in certain cases. Severe spinal stenosis, ultimately a surgical operation is needed, a surgical decompression. But I think that's where also the importance of having a knowledgeable pain practitioner who's knowledgeable in preventative care comes into play, so that you can head these problems off at the pass before they become serious issues. I can't tell you the number of patients I encounter almost on a daily basis who say, I tell them what's going on. I tell them frankly and honestly, I want to put a positive outlook on things, but I tell them, I'm not one to beat around the bush. This is what's happening. This is what has developed over, let's say, the last, 5 to 10 years. And they say that's really a shame, because, I had this 10 years ago and I just wanted to ignore it, and I just persisted, and now I have to have surgery, So it's important on our, from our standpoint to really stress the importance of preventative care, because preventative care in pain medicine is the same as preventative care with a general practitioner. We can head off a lot of serious problems at the pass before they become serious with good surveillance.
Yeah, I was thinking about it, because I was like, okay, preventative care, but you're already in pain. So how would a person know they need to come see you? Is because they may have a family history, or just...
Yeah, it's such a tough question to answer, Dexter. And, you don't want to overreact to every little thing. You don't want to overreact to, hey, my fingernail is ripped a little bit, I got to go see someone. No, it's not that, but it's also, you don't want to see the person where they're coming in and they're borderline paralyzed because they have such bad spinal compression. So I think, maybe the ultimate answer is, anytime there's a sign of any sort of pain complaint, whether it's especially coming from the spine, because the spine is a very, very peculiar sort of structure, and it needs to be loved and caressed and all this stuff, because, you've seen what can happen if that's not the case. And I'm sure people listening to this have had friends or family and have to undergo spine surgery emergently or urgently. It's very important to at least talk to, your healthcare provider. And then we have to have trust in our general practitioners that they get those patients, or they get you to see me or whoever else it may be that needs to evaluate the patient.
I know before mine flared up, I was in pain for 6 months.
Yeah,
I mean, it was
that had to be pretty debilitating.
It was a long time, and I was going like, okay, just dealing with it, just keep pushing, because you're working in the corporate world every day, and you got to go to work, and if you get off work, they're gonna have a complaint, or you lose your job and all this stuff. So you just keep pushing, and that's what I did. I just kept pushing until one day I just completely collapsed.
Yeah, it's unfortunate because there are a lot of societal stresses. There are a lot of familial, family related stressors that make people persist. If they can get up and they can go to work, they're going to do it, even if the warning signs are there. And so if there's anything we could take away from this, maybe it's, don't ignore your health, set aside an hour to see someone about it if you feel like something's happening. I'll personally attest, I don't always follow my own rules. I have 2 small kids at home. I have a full-time job that's really busy. I go to the surgery center. I go to the clinic. I go to the hospital. Sometimes I don't even have time to think about, my pain or, my health or things like that. So maybe I'll take something out of this at the end of the podcast.
I mean, that's you have to remember that, because I think
exactly.
I've from what I've learned from my experiences now, to focus more on myself and take care of myself. And just by doing this podcast has really given me more energy, more strength, because I can share my story and I can talk to other people. So it makes me feel that I'm doing something for the public as well.
Yeah. That's wonderful to hear.
That's important, because I just don't like for people to be in pain. I don't want nobody to be in pain. I'm sorry. Don't come crying on my shoulder. I gave it to you.
That's what Valora's over here for.
That's right. Don't come crying on my shoulder at all.
Yeah.
So you spoke about the spinal center. I mean, the surgery center.
Mm-hmm.
What did y'all do in the surgery center there?
Yeah. So we do things that range from, let's say, quote unquote, simple injections. Let's just say like an epidural steroid injection, which of course, takes years of training, but once you've been doing it for years, we can call it quote unquote simple, to more complex procedures like surgical implants, things like that. Like we talked about earlier in the show, for say intractable neuropathic pain, which is nerve related pain, where a person is just having, let's just say, shooting pains and burning pains in their leg all day, regardless of position, regardless if they're awake, asleep. What we can do is put a little tiny implant along those nerve roots and send an electrical signal to those nerve roots to kind of, I wouldn't say trick it, but get it to more behave like it's supposed to behave and send the signals like it's supposed to behave. So those are some sort of complex, I would say, quote unquote, complex surgical procedures I do. So the range of therapies we offer at the surgery center are, simple, let's say, soft tissue injections for tennis elbow, for knee arthritis, and they range as far enough as having, let's say, some spinal cord damage, where we put an implantable in to help treat that spinal cord damage.
Now, is that the same as was it Vertiflex Superior?
The Vertiflex is a little bit of a different device. So the Vertiflex treats mechanical pain. And when I say mechanical pain, that's pain that changes with the person's position. So a lot of people, and you probably see this, and you'll see this now if I sort of elaborate on this, people with spinal stenosis tend to want to walk hunched over. And you'll see these people at the grocery store, Costco, on the street. They're just, guns blazing with their shopping cart. They're hunched over and they can go for miles. But the minute they stop and stand up and they try to walk without support, they can't do it and they have to sit down. That's something that Vertiflex can help with, where we kind of expand the space in a sense between the lumbar vertebrae, again, those bones that comprise the low back. We kind of expand that space with a titanium device in a non-surgical sense. It's almost like an injection in a sense. And we keep that device in there lifelong, and it's to keep open that space so that the individual doesn't experience the burning pain in their legs when they're walking. So I'm sure that you and anyone listening to this now, when they see people in the store and they see someone humming along,
I'm gonna know now.
You're gonna know
like, whoa,
they have spinal stenosis. They need to see Dr. Valor or somebody else, because they can get that fixed. It's kind of sad. You see them, that these are people who actually love to go to the store because it's the only time they're out of pain, when they have a shopping cart, when they have a mobile device they can hunch over on. But the minute they're home without support, unless they have a walker or something like that, they struggle and they suffer. So that's a little clinical pearl you can use for your own entertainment, I guess you could say.
That is because I've always thought it was just something, just it was genetic. As people get older, they just hunch over.
No, that's related to compression in the spine, and the act of hunching over expands the space in the spine. The minute someone kind of tries to stand up straight is when they're going to compress those nerves, and they're going to get debilitating, burning, achy pain down the legs.
So let's touch base a little bit on the arthritis in the knees, because I think that's a number one for everybody these days.
Yeah, myself included. I had big time knee surgery about 10 plus years ago.
Wow.
And, I'm in my latest 30s now, and, I'm suffering from it. Arthritis afflicts, would have to say the vast majority of people, above 50, above 60, especially with the societal demands that are placed on us. The treatments for knee arthritis, again, and we go back to this preventative care, if treated somewhat aggressively. When I say aggressively, I don't mean invasively. Aggressively and invasively are different terms. Invasively means, some complex surgery, whereas aggressively means, going to physical therapy 3 to 4 times a week for quadricep strengthening to take the stress off the knee to prevent progression of arthritis. That's an example of aggressive treatment. The treatments for knee arthritis are continuing to improve, and this is one of the therapies that I'm hopeful of really blowing up here, so to speak, in the next 5 years or so. Classically, our treatment options were steroid injections in the knee, cortisone injection to reduce the swelling, or knee replacement. We're sort of starting to get more therapies that are in between those two, between the steroid injections and between, total knee replacement. You've probably heard of people saying, I used to get knee injections, they worked great, and now they just don't work anymore.
Yeah.
That can be more than likely, that's just a progression of arthritis, because steroid injections themselves, even though they treat pain, they can decrease the time to knee replacement. Does that make sense? They can actually decrease your time to knee replacement, because the medications you put in a steroid injection are actually somewhat harmful to the soft tissues in the knee. So even if you're getting good pain relief, you're actually sort of degrading that tissue a little bit. So we have things nowadays that are things like viscosupplementation, where we can put an artificial gel matrix in your knee that's supposed to mimic your own cartilage. That works very well for sort of early stage arthritis. So it's probably something I'll have to explore here in the next couple of years. And we're also making headway with peripheral nerve stimulation. So peripheral nerve stimulation involves, stimulating the peripheral nerves that sense pain from the knee. And what that entails is putting a little tiny implant. It's almost, maybe I would say 2 or 3 times the size of a strand of hair, where we can implant that under the skin and turn on some stimulation with a battery pack that just actually transmits current through the skin. It doesn't hurt or anything. And we can stimulate those nerves so that they do not send painful signals all the time.
Wow.
Yeah. So that is something I'm very, very hopeful of taking off, because, there are a lot of people who have progressive arthritis, maybe let's say stage 3, stage 4, meaning sort of close to end stage arthritis, where they need a knee replacement or bust. And they simply can't do it for either medical reasons, for family reasons, where they're not able to have a knee replacement, because that is a very, very big time surgery. And, a lot of people who would benefit from it maybe have, medical issues that would preclude them from having that. And then at that point, what do? You're kind of out of options,
Yep.
So I'm hopeful that peripheral nerve stimulation, as we start to delve more and more into those neural pathways, becomes a very viable treatment option. And our job as a specialty is to promote those therapies as cost-effective, minimally invasive, safe therapies, so that insurance carriers recognize the benefit of that, and don't just tell us, well, your 2 options are to have this knee replacement that could create a bad outcome because of your heart disease, or take an opioid for the rest of your life. So we need to figure out something in the middle there, and I think we're very close to doing so.
So let's go back. Let's just you made a comment right there. We said insurance companies to recognize the benefit.
Dexter Brooks, the insurance man, is here.
So do you know what that process is like for you guys? Can you touch base on that? Because a lot of people like to know, because if people get insurance, they wonder why this is not
covered. It's a very frustrating thing for the practitioner as well as for the patient. It's a very slow process to get things approved by insurance. And before these things are taken to insurance, there's years and years of clinical evidence that's compiled to present to these insurance carriers as saying that this is a safe, viable, long-term solution for this type of pain. The problem right now, I would say, is that each individual insurance carrier abides by their own clinical policies. And sometimes those clinical policies are cut and dry. Sometimes they're not. Sometimes the insurer is open to hearing about new therapies. Sometimes they're not. The real issue is making sure that insurance carriers evolve just as we are evolving as a specialty as well. So unfortunately, the long story short is we don't have direct influence, I guess you could say, although it is our job to ensure that we provide the necessary evidence for those insurance carriers to make the appropriate decisions in what's covered and what's not covered. The problem with pain management is because some of these areas are so gray. It's not like, hey, we want to get this screw approved for a knee replacement because we know that the durability of the screw is great. Here's the evidence why. That's a pretty clear-cut outcome. Whereas in pain management, again, we can measure so many different variables: functionality, quality of life, pain scores, sleep, mobility, functionality in measuring certain metrics like how fast you can run after something's been done. All of these things you can measure. What do people go against? There's no standard necessarily, so you can almost provide carriers with overabundance of information, which allows you to not make a very well-informed decision because it's too much information. So, I'm of the stance that too much information is better than too little information. And I'd rather be able to measure a number of outcomes and variables rather than just X plus Y equals Z, personally.
Now, can the public play a part in happen to?
Absolutely. For a number of my patients who, let's just say they're quote unquote stuck. They come to me stuck, meaning they've exhausted all conventional options and, their insurance carrier's not approving a therapy that I think may help them. And let's just say that therapy doesn't have robust clinical evidence for it, but it has very robust anecdotal evidence for it. When I say anecdotal, it's just sort of case studies and stories we hear from, well-respected peers in the community. Part of the reason as to why we can't get robust clinical studies done is because you can't severely injure someone and cause pain and then try a therapy on them. You see what I'm saying?
Yep.
You would never do that to someone. So the once in a year person who comes in who maybe has this complex issue related to a bacterial infection that is caused from a superbug that's affected one specific part of their abdomen, how do you compare that with 100 other patients who have that? Nobody has that. It's one of these, once in a blue moon outcomes. And we have to know from reasoning and understanding these pathophysiologic mechanisms that, hey, this is an expensive therapy, but I think it's going to work. This implantable device, I think it's going to work for this patient. And it's up to us to fight for that therapy because, the patient can only do so much. They call their insurance company and the response is, well, we don't cover this. Well, it's on the physician to then provide any anecdotal evidence, any pathophysiologic evidence to support that, to see if we can get it approved for them. So pain is definitely unique in that space because it's not like blood pressure, getting a blood pressure medication approved. If we've established the safety of a blood pressure medication in 500 patients and their blood pressure comes down, great. But for us, we're not going to go out and injure 500 people and cause a problem, cause pain. It's when pain comes to our doorstep that we have to figure something out. So that's very challenging for pain.
Awesome. All right, I'm going to take 1 minute here because we need to give a shout out to our sponsor, HNC Let's Talk Podcast. Our sponsor is HealthNet Co. Insurance Agency. Together, we make insurance simple. Got to get the shout out.
Shout out, baby.
Yeah, absolutely. I mean, because I know back in the day it was so hard to get carriers to cover anything. You would say, hey, you know, the doctor got this, the doctor did this, and they wouldn't listen. I know they're doing a lot of changes now. I've worked with several carriers in my career, and the ones I do know do listen.
That's good.
So,
I think there is a little bit of a paradigm shift, especially with pain, because, you know, we don't have to relitigate the opioid crisis. I mean, this has been in the news, dominating the news, I guess, prior to COVID. But, you know, for the last several years, the opioid, quote unquote, crisis has been dominating the news. And while, yes, I'm sure there were some unscrupulous individuals who were sort of promoting that as a path of least resistance, there was also an inability to get certain things approved, as you were alluding to, that made opioids the only option that was affordable for the patient, the only thing that was covered by their insurance. And I think insurance companies are starting to open their eyes and realize, well, hey, we can't just recommend that they go on opioids for the rest of their life. You know, let's say a 32-year-old mom of 3 who has an injury, who has a, you know, potential for success with this procedure. Yeah, you know, maybe it's a little expensive, you know, quote unquote, for what they want to cover, but do we want to put her on morphine for the rest of her life? You know,
right.
Patient sure doesn't want that. The doctor sure doesn't want that. You know, why should the insurer, you know, send us down that pathway? So I'm hoping that this wave continues to trend in the other direction. So
Yeah,
it's positive.
I mean, because I'm not too thrilled about being a morphine person myself, but I have no other option right now.
Yeah, you have
a
big rod in your back.
So it's like,
it's gonna hurt.
You know, so it's like, okay, people, can I find something else that I can take or something else I can do? You know, I've tried everything else. It's like, but right now that's the only thing that will work.
Right. You know, I think we're making headway into finding this elusive kind of ideal opioid, you know, an opioid that provides pain relief, meaning it works on the receptors that treat pain itself and does not work on the receptors that induce, you know, poor outcomes, things like addiction, tolerance, respiratory depression, which in high doses leads to, you know, cessation of breathing and overdose, things like that.
Yes.
We're still a few years away from it. From my latest reading, unfortunately, we're still a few years away from it. You know, we're probably looking at the late 2020s at this rate. I hope I'm wrong. I hope it's earlier, just like I hope I'm wrong with the COVID vaccine. I hope it's sooner rather than later. But until we get that elusive opioid, we're going to continue to fight for all these therapies that we think patients deserve.
So not to come off there and things. So you're in the practice, and I know that the COVID made a hit on you guys because you guys was closed for a while.
Yeah,
that hit me. I mean, I was like, hey, I got pain.
Yeah,
you know,
yeah.
It's like, have you guys started back? Are you open up now?
Yeah, we're open up. We were reliant on telemedicine for a long while there. You know, there was a stage at the end of March 2020, beginning of April 2020, where, you know, it was kind of like a ghost town. And, you know, there was so much focus on COVID, and appropriately so. People put the rest of their health concerns on the back burner. Fortunately, you know, I can only attest to Colorado since I've been here for the entire time. I think we turned it around rather swiftly as compared to some other states. And we were able to get patients back in the doors and to get the treatments they needed and they need. And it's not just the field of pain management, but also other disciplines, you know, things like oncology, where maybe things are a little more pressing.
Mm-hmm.
Maybe they're still considered elective, but they're still pressing. I think those were that whole thing was turned around rather swiftly. So I'm glad that Colorado has continued to do well from a public health standpoint. And I hope it continues into winter 2020.
Wear your mask, people. I want to say that 1,000 times. Wear your mask. So our providers can continue to serve the public and provide these necessary treatments. Otherwise, we're going to be right back where we were. So I'm going to have to throw that out there real quick.
Wear your mask, wash your hands, keep your distance. We can we can have a normal life as we can. Of course, it's a trying time for all of us right now. No one likes to wear a mask. No one no one likes to not see their friends.
But you
and
probably
things like
wear
that.
a mask for 60% out of your.
For me, when I'm in the operating room or I'm in the hospital or I'm in the surgery center, I'm wearing a mask. So for me, it's no problem. But I thoroughly sympathize with everyone where mask wearing is kind of newer. Believe me, none of us want to do it, but the more we do it, the sooner we get back to some semblance of normal life, and some semblance of normal life, presumably before a vaccine, if we continue the positive trends.
Awesome. So before we wrap up, is there anything you want to leave today? But what I want to do, first of all, I want to touch base on your practice.
Sure. Yeah.
So tell us about your practice.
Yeah. So we have a small community-based private practice in Greenwood Village, Colorado, called Colorado Pain Consultants. It's myself, my partner, Dr. Joseph Fillmore, and a nurse practitioner, Carly Green. We essentially see everyone, the door doesn't close for anyone, any condition. We don't discriminate based on health insurance carrier. We don't discriminate on past medical history, nothing like that. We see everyone, anyone we can help or anyone we think we can help, we see them. Again, it's just sort of small community-based private practice. And I would say I'm more of I do a lot of the more sort of complex stuff, like we were alluding to, the implantables and things like that. I like doing that type of stuff.
So you're the surgery guy.
Yeah, well,
the injection guy.
Yeah, I'm not I'm not a true surgeon. I would say, rolling in with my knife and fork, but I do like to do things that are more definitive in a sense, where we can put something in and let's say we turn on a device and the majority of pain is eliminated. That.
So you're like a high-tech doc.
Yeah, maybe call me Silicon Valley, Silicon Valley, Colorado. I like seeing improvements right then and there. Of course, we manage chronic things and things take time to get better and stuff like that. But, this morning on a patient of mine, they have multiple sclerosis. I fought for 19 months to get a therapy approved for him. And this is a true story. And I did the trial implant this morning, and she finally has relief of pain in her legs.
Wow.
Yeah.
Awesome.
And that's I'm not making that up for this podcast. That is what I did before I came here. So the fact that we're able to do this, we waited 19 months. Unfortunately, we had to resort to some mind-altering medications like opioids because her pain was so severe, and it's continued to progress over these last 19 months. But we were finally able to get a more definitive solution, at least the initial stage of it, on board today. And that's really like an on-off switch. I mean, honestly,
That is an on-off switch.
And we control it through an iPad wirelessly. So it's literally turning the iPad on, pressing a button on the app, and turning on stimulation and having an elimination of the bulk of pain. So for me, that's very, very fulfilling. And so when I have a day where I look at my schedule the next day and I see these types of things that I'm doing, I get really excited. I mean, I'll be honest. Don't get me wrong. I like going to clinic. I like managing, soft tissue, muscle pain, low back pain. But when you can really change something in an hour, where you can change a person's life, that is really special. And so I'm very privileged to be able to do things like that.
I have to applaud you for that one. That's 19 months.
19 months I fought with an unnamed insurance carrier. Let's put it that way.
19 months.
I don't know if Dexter Brooks was involved in this. No, I'm just kidding.
19 months.
19 months. Yeah. And it was painful for me. Imagine how literally and figuratively it was painful for the patient.
Yeah, the patient has to go through that for 19 months.
19 months.
And today they finally
achieved meaningful relief. I mean,
wow.
Yeah. Not for COVID, we probably would have had a party or something.
Yeah, absolutely.
Seriously. I mean, that was really a good story. Yeah. I'm not.
Because like I tell people don't realize chronic pain can have you in a fetal position. That's how bad it can be.
Yep.
And you can't move, you can't do anything. The only thing you want to do is be in a fetal position. That's it.
And there's the mental component, just the exhaustion of not only experiencing pain, but thinking about it, having it consume you. And then you have the consumption of knowing that there's no help on the way because we're just stuck here fighting.
Yep.
That was pretty special. I'll be honest.
Wow, man. And that's what's the name of the practice again?
Colorado Pain Consultants. We're in Greenwood Village, Colorado. Stop by anytime. If you need help with anything, we'll get you fixed up, or we'll get you to someone who will fix you up.
What's a good contact number?
303-792-2959. We are on 5975 South Quebec Street, Suite 150, Greenwood Village, Colorado 80111. Give us a call. Let us know that you heard me on the podcast, and we'll get you seen and fixed up.
Absolutely. And if you don't remember the number, you can always reach out at healthnetco.com, because I can give you the information with no problem whatsoever. Because these guys are awesome. Like I say, if it wasn't for them, I probably wouldn't be doing this podcast now. Because I was, majority of my days are pain. And I'm now I'm waking up a little bit and started the podcast, and things are looking a little bit brighter for me. So
yeah, I appreciate you very much. I appreciate you very much, Dexter, for having me on here, and I appreciate what you're doing. Thank you for doing this, and thank you for helping people.
Now, we'd definitely like to bring you guys back on here, because there's a lot to be talked about.
There is a lot to talk about. Like I said,
education is important.
Education is very, very important. It's very important to be a self-advocate too. Don't let anyone dismiss you or tell you anything. Make sure you advocate for yourself, and we can help do that for you too.
All right, guys, this is Dexter Brooks with HNC Let's Talk Podcast. We're going to get ready to wrap this up, and I want to make sure everyone has a great day, a great week. And again, I want to thank Dr. AJ Valor for joining me out of his busy day, because he was in surgery. Can you believe this? And he came by here. So
I'm off to the hospital right after we're done with this. I'm not joking.
All right. Until next time, everyone be well.